My name is Catarina DeMarchi Assuncao. I am a fourth-year neurology resident here at University of Louisville, and it is with great pleasure that I am here today to share a few ideas on a topic that, to my interest, is very pertinent, and I think it will probably fascinate you guys too if I manage to achieve my main objective here. So everyone can see my slide, right? I tested this before. I believe you can hear me, so let's move ahead. All right, so my goals for today will be of a learning objective that is describe the project of monitoring heart rate variability in patients with electroencephalogram or EEG and the potential implications on their health. The learning outcome is that I hope we can increase awareness of potential applications of HRV, the heart rate variation, monitoring as a biomarker of autonomic health in different neurological scenarios. And so heart rate variability, even on its name itself, it implies that the heart rate is not entirely steady. And someone who is healthy, normal subject, they should have it increasing during exercise and decreasing at rest. But also you have a moment-to-moment variability that happens even at rest. So the resting heart rate, it varies at a short time interval due to respiration, which is something that we learn early on when you're examining a patient, that you can find respiratory sinus arrhythmia. This is more commonly seen in younger subjects and younger patients, especially kids. And also you have variations of your heart rate just secondary to blood pressure and the parasympathetic nervous system. As I mentioned, the parasympathetic nervous system is at play there, regulating blood pressure. You also have the sympathetic nervous system that will be responding in a way to the circadian rhythms. So circadian rhythms are just something that we all have, ideally, approximately every 24 hours of our many internal biological processes that cycle like this. And there's a big play of the sympathetic nervous system here. And a good example of a circadian rhythm, of course, is your sleep and rest. You can anticipate that your heart rate will be different when you're sleeping versus when you're moving around. All right, so before we talk about some applications of this variation, I wanted to bring everyone up to speed to some concepts and background. So depending on your level of interest in anatomy and physiology, you may remember this, or this may be a fresh start. But there is something called the cardiovascular parasympathetic activity, which is basically the communication between brain and heart in terms of the different processes you have in your body going on. And ideally, they should be responding appropriately to the environment or to things that are happening with the patient. So I'm not sure my mouse is visible. I don't think so. But if you look at the picture to your right, you will see that there's a little illustration of a sagittal cut of the brain and a little heart there and some connections. So the cardiovascular parasympathetic system, it is modulated by this part on the dorsal part of your brainstem, and some other components of it include the nucleus tractus solitarius, nucleus ambiguus, and dorsomotor nucleus of the vagus. So all your lower brainstem cranial nerves, they will, especially represented by the vagus, will be acting in regulating this activity. You can also have a response of the parasympathetic nervous system to sympathetic activity, and this will be a little bit more ventrolateral medulla, so a little bit more to the front of the brainstem there. And if this area has increased activity, you will have increased sympathetic firing, and this will transmit itself to the heart and will also be transmitted to the kidneys, that you can see here represented by this small beam here. And this increases your blood pressure. So this is a very simplified way of reminding everyone of this connection. Right? There's something else too that, as they go in neurology, someone who was very dedicated in exploring anatomy described, and is called the Pontine curfews nucleus. This is the main area that is responsible for this sinus respiratory arrhythmia that I mentioned. So it's this variation of your heart rate that you can encounter in normal subjects when they're breathing and taking deep breaths, and you have a slowing of your heart rate, and then exhaling, and your heart rate bumps up again. This is physiologic, or this is expected, and it's a normal response. And we could go on and on about how this is related to how blood flow works in the heart when you have increased or decreased thoracic pressure, but this is beyond the topic. The main reason I'm mentioning here is just to remind you guys that we're talking about heart rate, but we're not talking only about the heart, and we're talking about brain health or some brain diseases or nervous system diseases, but of course this is all interconnected, and it will be connected with your heart, with your lungs, with your respiration, with your level of activity too. And this is just a cut on your right that shows you that you actually have represented in different colors there, green, red, inspiratory and expiratory neurons, which I find it fascinating that you have such delicate structures controlling your vital functions there. Okay. So we can move on to a little bit more of a applicability, and it is reasonable to bring up a bit of how everything came into place. So in the 1965, Hahn and Lee, they noted that fetal distress was preceded by alterations in the interbeat intervals. So this is just their concept to say variations of the intervals between each heart rate, each heartbeat. And this happened even before you could really see a change in the heart rate itself. So this was a very rudimentary analysis of your heart rate variability and how it could have an impact in signalizing distress. And if you think about it, this is a significant tool because it's if you're able to measure that without being invasive, you should be able to provide better care for expected moms and their babies. So between the 1980s and the 1990s, it was started to be recognized that there was a bigger relationship between the autonomic nervous system, which was what I briefly explained, a little bit of anatomy and physiology in the last previous slides, and what relationship it had with the cardiovascular mortality. And then in the 1990s, you had a popularization of commercial devices that were better equipped and they were more available, cheaper, and were able to automate heart rate variability measurements. So this led to more of an explosion of applicabilities, and it's really what we're going to talk about over the next two slides. So yeah, we said, how can we apply this information? So I decided to divide this into what we can see in different systems. So the most well-known association and that has been better proved is the association with the prognosis of patients that suffered MIs or myocardial infarctions and survived them, on how they would fare in 30, 60, 90 days after that MI. So patients that had a higher, so an increased heart rate variability, they were at a higher likelihood of doing better, of having less morbidity and mortality after that infarct versus the patients that had a lower heart rate variability. And so, of course, as it goes with many physiological processes, it's hard to really be 100% sure on the reason behind it, but it seems like on patients that are sicker, the heart rate variability will be more affected or more deranged because you have this geometric change of the heart. And if you think about how the heart should be working, you have the sinoatrial node. So I abbreviated it as SA here. And you should have the sympathetic stimulation coming from all above, and this should fire the heart to start beating, and the sinoatrial node will control this spread of the electrical current throughout the heart. And you can see, and you can imagine that if you don't have a very well organized geometric structure of that heart anymore, because you have areas that are necrotic, areas that are not contracting or hypoactive as they are described in echocardiograms, you will definitely not have the best communication electrically between those firings. And so you will have all sorts of arrhythmias, but also to our topic here, they will have less of a heart rate variability because, as we saw on a normal subject or on a normal patient, you should have a bunch of systems communicating, and this information should be transmitted equally to all parts of your heart. So if you infarct in one part or many parts, this will not be the case. And so you will end up having a feedback of increased firing of your sympathetic fibers, because again, this heart is all deformed in terms of structure, and it signals weird things to your sympathetic system. And, the sympathetic system in this situation would be firing up your heart rate. But then when it does this, it attenuates or it suppresses your vagal fibers that are parasympathetic. And then you just have your constant heart rate being up and not variating down, which we could go on how patients are started on beta blockers after an MI, partially because there's a benefit in controlling a little bit of this increased sympathetic activity. This is the best known relationship, but we have more. And one of the most interesting things is that for many biomarkers in medicine, sometimes we focus a lot on disease and illness, which is fair because this is something important in what we do. But heart rate variability is also something that is of a great interest in athletes and in performance training. So again, you have this interplay of parasympathetic and sympathetic activities. So you have the moment that you're exercising, and I'm talking more about aerobic exercise, so the ones that really make your heart rate go up. You have more activity of your sympathetic nervous system and a decreased activity of your parasympathetic nervous system. But of course, as you finish your exercise, this again balances out. So not unsurprisingly, people who have an increased fitness with their physical activities, so big athletes, big shot, and people who are really doing sports professionally, they have greater heart rate variability than someone who's healthy but is not playing sports at that level. And so we mentioned aerobic training being the contributor here. In patients, however, that trained very heavy in a day, the heart rate variability that day may be a little decreased because that's a lot of firing. So in that acute scenario, the heart rate variability decreases. But in the global sense, it tends to be higher. In patients that they are training and they see that the heart rate variability is lower in the day, this may indicate and may correlate with lower performance ability. There was a study that tested between cycling, walking, running, and most of the differences, they were not statistically relevant. The only thing that was interesting was that the heart rate variability recovered more quickly after cycling. And again, this recovery is, I'm talking about the acute reduction that you have in a more intense scenario. So in cycling, you go back to your higher heart rate variability quicker than the other scenarios. They're walking and running, just as it goes, right? As we would expect in healthy athletes, if they have sleep deprivation, significant sleep deprivation, so just sleeping 3 or 4.5 hours at a time, will decrease the heart rate variability. Also, not surprisingly, alcohol could impact it, and smoking tobacco. This has all the other implications that we know have for your health and for athletes, like performance athletes. This is very significant. But it was also interesting that they saw that life stressors, so things that are more abstract, right? At least in the sense that you don't have it so objectively seen there. But of course, when you're going through emotional stress, anxiety, depression, those things are very much real. They also have an impact in heart rate variability. So, how can we apply this in different neurology scenarios? So the first one that I put in here in neurology is stroke, and this I made it in purpose because unfortunately we are in an area here that has been known as the stroke belt because you have different risk factors that make us have an increased risk and increased incidence of all sorts of strokes, but more specifically here, the ischemic strokes. So I think knowing more about tools to evaluate the health of our patients is always a good idea, and especially in a disease that has such big impact in our patients. So there were prospective studies with the general population and just observing them through time, and they saw that there was a relationship between heart rate variability and incident stroke. Again, lower heart rate variability is worse and puts you at an increased risk. It seems that hypertensive patients with reduced heart rate variability have a higher risk of stroke and acute coronary syndrome, or ACS, so infarction of their heart. Stroke patients that had the decreased heart rate variability, as I mentioned before, they will have a higher mortality and they can have a poor functional outcome. So they will be, unfortunately, doing less after 90 days if they have a heart rate variability that is lower, or they will likely be doing less. And this is potentially because of this dysregulation between central autonomic network that would cause myocardial injury. So that's an interesting concept because we see troponin rising and we see some cardiac biomarkers increasing in patients that have had acute ischemic strokes. So there's all this interplay and relationship. And then with myocardial injury, you should remember about all the talk that I had about the geometry of the heart being affected and causing all sorts of issues. Or this could be just because the heart rate variability being low, it already reflected that they had increased the risk factor for many other issues. So it's not necessarily directly related to the injury caused by the stroke. And then finally, on stroke patients, there was this unclear relationship between reduced heart rate variability and recurrence of a stroke. So we talked about how it put someone at a greater risk of having an incident stroke and also of having worse outcomes. But recurring strokes, they couldn't find very well of a relationship. And it could be because this was blunted by the fact that once you have a stroke, you are started on different medications that could actually protect you from this postulated damage that would cause your heart rate to vary less. And so all the beta blockers or the inhibitors of the renin-angiotensin-aldosterone systems. So that's there's room for studying specifically more about that. And so that we wouldn't leave behind the peripheral nervous system, there's also a known relationship between heart rate variability and diabetic neuropathy. And you would think that this makes sense because you know that some patients in the long term of their diabetes, they will have their vagus nerve being affected and they will have all sorts of dysautonomic symptoms. So dysregulations of blood pressure, heart rate. But we are here talking about peripheral neuropathy too. So it seems that patients that have peripheral neuropathy caused by diabetes, having a heart rate variability that is lower on the onset, um, again has a negative prognostic value, but it also seemed to proceed. So it seems to manifest itself before the patients will actually develop the autonomic dysfunction. This autonomic dysfunction is described in some cardiology journals about in internal medicine with great interest because it is something that affects a lot of problems or potential issues for the diabetic patient. And I found it interesting because it affects them not only at rest, so with increased tachycardia, because they don't have this very well suppressing. I'm sorry, there's a overhead announcement going on right
Your
now.
attention, please. Rapid response. 8.
Okay, I apologize. So patients that have this autonomic neuropathy caused by diabetes, they will have intolerance to exercise, so this perpetuates unhealthy habits, and then they start having silent MIs, so myocardial infarctions. They seem to be more prone to problems during surgeries, so intraoperative cardiovascular liability, and just overall increased risk of mortality. And you may ask me how prevalent this is in diabetic patients. The studies are all over the place. So you have studies describing a prevalence of 1 and up to 90% because they have different methodology assessments. But the final thing about this would be that it really has an impact that is bigger than peripheral neuropathy in diabetic patients. And again, not downplaying how much of an impact peripheral neuropathy have, but this is implicating in their cardiovascular health too. All right, and then cognitive function was something that really I found was interesting, that has been studied in some patients that have preceding the cognition problems. So cognition is not only memory, as we know, as there's a global aspect to it. It involves language, attention, executive function, visuospatial skills, and processing speed. Um, so having a cardiac vagal tone has been described to um, cognitive and emotional control. And so patients that have higher resting heart rate variability, so healthier activities of this, they will have more inhibitory prefrontal subcortical circuits. So this helps in your overall global functioning of your cognitive functions, responding better to your environmental demands. So they found that there are different domains affected. The memory domain seem to be a little related to how low or higher heart rate variability is, especially in verbal memory. They didn't find much of a difference in visual memory. And so it could be because visual memory has more areas of your brain involved in it than the verbal one. And this would involve more or less your central autonomic network. Again, very fascinating. Room for lots of speculation here. Other topic of interest would be this seen in Parkinson's disease, atrophy, or progressive supranuclear palsy, dementia with Lewy bodies. So as with diabetic dysautonomia, you also can have all sorts of dysautonomia related to those diseases mentioned above. But early stage Parkinson's disease, it even without having parasympathetic nerve dysfunction, so no orthostatic hypotension yet, they can still have lower heart rate variability, which already indicates that you're not having a very good sympathetic function of your communications with the sinoatrial node. It is also something, the heart rate variability being low, that has been associated with olfactory impairment, is a thing seen in Parkinson's disease. Not surprisingly, with multiple system atrophy, as we know, you have bigger dysautonomia, but they also have bigger impacts in the heart rate variability. The PSP was not so clearly correlated with lower heart rate variability. But dementia with Lewy bodies, there was a relationship with reduced vagal denervation in the heart. And then again, going back to one of the things that was maybe one of the first things that caught the attention of researchers about the heart rate variability, that was monitoring intrautero and then peripartum. The heart rate variability in neonates with hypoxic ischemic encephalopathy seems to be something that when you have a lower heart rate variability, it does correlate with cerebral injury. So in this sense, you could maybe have a promising biomarker that would allow you to be more specific about hypothermia and all the treatments that you have specifically for HIE, perhaps oriented by what you see in the decreased heart rate variability. Then there's heart rate variability in epilepsy. This is something that is very dear to neurologists in general, but everyone that deals with epilepsy should be aware and make patients aware about sudden unexpected epileptic death, SUDEP. So again, I'm repeating the same motto, but there's increased cardiac death in patients that have reduced heart rate variability and have epilepsy. So there's a relationship with SUDEP and reduced heart rate variability. And then the simplicity of how an EEG is done in terms of how the patient has to be positioned. So they are at rest, laying in a bed, and will be there for several minutes or even days in more prolonged minute monitoring. So it is a favorable situation that you could assess resting heart rate, and you could have a lot of information about their heart rate variability in this scenario. So with all of this, there was an idea that was born. This is Dr. Evans, the first one in the left picture, Dr. Sagi and me. They both are epileptologists and professors here at University of Louisville. So the idea is that how feasible would it be for us to look at how the heart rate variability changes or behaves during just routine electroencephalography? So just for whatever reason, a patient goes into electroencephalography or EEG, and in that, you would have monitoring of the heart rate, and I'll talk a little bit more about how this is done. So we wanted to see, because in the standard of doing an EEG is to getting a one channel, single channel EKG or ECG that is mostly used in EEG in adults to control for some artifacts that can happen with the heartbeat. But it has some value of looking into heart rate, and we wanted to see if it was something that we could extract heart rate variability for patients that were already getting an EEG done, and then to also see if having a normal EEG would imply that you would have a normal or close to normal heart rate variability. So this is ongoing. Our idea is to analyze 100 normal adult EEGs. We're quartered through this, but this is EEGs that were done for various reasons, 20 to 65 minutes, and they were done at one of the University of Louisville health system, either at the University Hospital or Jewish Hospital, or even the HCOC clinic, and it was with adult subjects, 17-year-old or older. So again, whatever purpose they were ordered for, that didn't matter. We took out all the identified information, but still kept age, sex, and what was the interpretation of the initial reader of the normal study, and of course the EEG itself. We did not include patients that had atrial fibrillation or a cardiac pacemaker, because this would mess up on some of the parameters that we're looking at. The machines used were the Nihon Kohden or a Natus Exaltec. And this was a single lead recording ECG or EKG, which, if you look to your left, is when you position one electrode subclavicular on the right and one on the left lateral chest. And there are papers that will describe how the lead 2, which is the one that is used in EEG and also on usual monitoring of patients on telemetry. This is very good for heart rhythm. Of course, not very good for ischemic ST segment changes, but this is not what we were looking for. Everything was digitized at this 250 hertz with some filters. So filters will help you take away some of the noise that comes from light and environment. And on the left there, I have just a little bit of an example of artifact coming from muscle, and then you apply filters that will have a high pass and a low pass, and you can determine that, and you get to see a little bit of cleaner EEG. And we also had the IRB, University of Louisville Human Subjects Committee approving the study. So when you look into how you calculate heart rate variability, usually 5 minutes for short-term evaluation of the heart rate variability, and 24 hours when you're looking at heart rate long-term. We used 5 minutes because we were doing a shorter version of EEGs. So we only reported heart rate variability in a change of state that lasted at least 5 minutes. If it's lasted more than 10 minutes, then we said there were 2 successive heart rate values and so on. In any stages that happened in less than 5 minutes, then they were not included in the analysis. And stages, I'm talking about different things that happen during an EEG, mostly involving sleep. So how what does it look like is that you would have this one lead or single lead EKG going on. And what you see here marked in red, if you look at the QRS, or so look at the ECG and look at the highest peak there, you'll see that there is a little red dot. This is a fiducial point. And so we had first an automated checking of this interval, and then visually and manually done by one of the researchers, checking if this fiducial point was at a place that it made sense, as in, you can see in the first ECG strip, it does make sense because it's at the peak of the QRS there. But when someone has an arrhythmia or they have premature ventricular contraction or PVC, such as the one big QRS complex you see on the lower ECG strip, that should not be counted because that's not a complete heartbeat in the sense that it came all the way from top to bottom. And so you're not having a healthy distribution of your sympathetic and vagal tones. So this one was excluded, and so you only consider the NN intervals that are between usable heartbeats, right? So this is just basically describing everything that I said before. So you would get those NN intervals that we mentioned before between each heartbeat. Combine that with EEG stages, so patients that were in different levels of sleep, stages of sleep, arousal. Get parameters that I will talk about some of them in a bit as I show the results, but then basically analyzing time domain, frequency domain, and some nonlinear heart rate variabilities features. So time domain would be what happens with the heartbeats between a time epoch, so a determined period, and then you also have the frequency, what happens in that specific moment. So it's easier to talk about that, showing you guys a little bit of our preliminary results. So far we have looked at 25 EEGs out of 5 minutes of a supine relaxed state, which in different studies is the most common type of ECG used for this type of heart rate variability analysis. And we initially looked at the first 5 minutes of the resting awake state that had been recorded. And so what we found is interesting. This range of heart rate variability in our subjects was measured in the first 5 minutes of awake state, as I said. And to your left there on figure A, you have the highest heart rate variability on a subject that was a female of 52 years of age. And to your right, you have a 47-year-old that had the lowest heart rate variability in our study. And this plotted over time, which is the figure C and D there. Well, D, this presentation here on blue jeans decided to go out of format, but D is the fourth figure there that has this almost flat line there. So this is over 5 minutes of period of time. And this is interesting because all of our subjects, independent on of age, essentially, and some other parameters, they had a comparable lower heart rate variability when you compare this with what is expected of healthy individuals. So this table, I will not stay here too long, but what it shows you is what variables we were looking at, and you have what they mean. So you can look at some standard deviations of different things. So between NN intervals of how the difference between the NN intervals played here and how much the different intervals differed more than 50 milliseconds. And so you get all of those subvariables that are time domain measures. And those are well described in literature. And again, if you look at the first column here that says normal EEG subjects and normal values, normal EEG subjects are our 25 patients analyzed, and you can see that the normal range is higher than what we found in your mean NNI, the SDNN, and even RMSSD. So we also wanted to look at how the state of the EEG, different stages, would play a role in this heart rate variability. But of course, in our study, we were looking at a shorter interval. When you compare this with 24-hour EEGs or 24-hour ECGs that are done, you would capture much more sleep and all that. But we had enough subjects achieving at least some stages of sleep, N1 and N2, to be analyzed. So what we found is that, or preliminarily, you can record an adequate heart rate variability in ECGs that are done during EEGs. And of course, we recognize that there's lots of limitations in what we're doing, and comparing this non-controlled, non-randomized retrospective study with different studies that had more of a perspective and a larger populations is hard. But as I mentioned before, the interesting finding so far has been that even with normal EEG results, we had patients with reduced heart rate variability, and even time domain and frequency domains of heart rate variabilities are low in this patients that went for EEGs for whatever reasons they were having that done. This is much of what I had been talking about. I want to just go a little faster so we have a little room for discussion. So just basically in our study, we didn't see much of a significant change in heart rate variability correlating with sex and age. This was different from previous studies that found that there is a strong correlation with a great higher frequency of heart rate variability in females, and that also you have a decrease in heart rate variability with age. But again, this was found in different studies and so far not in ours. Sleep is also something that is interesting to be analyzed there. We found something that was a little different from previously reported. So in 2012, there were Stein and Pugh reviewing many polysomnography studies, and they saw that the heart rate and the heart rate variability decreased during non-REM sleep and increased during REM sleep. We had more of a trend towards greater heart rate variability in general during sleep. This could be because we were looking at shorter segments of sleep, naps basically, versus they were looking at full polysomnography or sleep studies. Then again, as I mentioned on the previous results, we found that the single channel ECG in patients that are going routine EEG is a highly feasible thing to be done. There's little change on state of wakefulness, sleep, or time spent during any given state. So what it means is that 5 minutes of a heart rate variability study during resting wakefulness could be sufficient for good characterization of heart rate variability. If you don't have that much of an influence of time, even a short segment that you look into could be useful. So we only looked at normal EEGs, and so patients that had some common EEG abnormalities, such as excessive delta or slow frequencies or epileptiform discharges, here they were not included. We had an expectation that if they had a normal EEG, they had a normally or relatively normal cerebral cortex function, and this would imply that they would have normal heart rate variability, implying normal function of brainstem, cardiovascular, and respiratory centers. But there's more to all of this, and we didn't find that. So patients that had normal EEGs, they still had heart rate variabilities reduced compared to normal values. So could we use the simple tool that is already available for us during routine EEGs to better stratify and assess risk for cardiovascular problems in our patients? So I have a few ideas, and I welcome the discussion on some other thoughts. So basically, could we do this on patients that, for instance, are undergoing routine EEGs and provide more information about risk of SUDEP or sudden death in epilepsy patients, as it is an easy way of accessing heart rate variability. You could potentially have a warning for neurologists that are following a patient. Also, because again, I mentioned that we have a large population in stroke patients, could we maybe develop something that we would monitor them again for shorter periods and look into the heart rate variability and try to correlate this with their outcomes? It's a possibility. And also I found that the potential relationship with cognitive dysfunction would be something else to explore. And we know that some patients, if not a large proportion of them that are having their cognitive dysfunction being evaluated, they undergo an EEG at some point. So you would have data coming from something that is not creating any additional invasive testing. You could stratify from that. And with this, I will have this brief part going through references here. Of course, if anyone is interested, we can share a more detailed version of this. And we open for a few minutes of discussion and talking and questions. And I know that Lilia.
Thanks for this talk. I certainly enjoyed it.
Well, you could be biased, but
I took notes on it anyway. So in reviewing all this literature, did you get the impression that the literature is kind of messy? That almost anything can affect your heart rate variability, and you mentioned some, sleep deprivation, alcohol, etc. Do you see any way to do systematic studies with it that could make sense, given that our patients have so many different ways of affecting heart rate variability, including all the drugs we give them?
You are right, Dr. Evans. I think this is a big confounding factor, is that you have so many even physiologic process and apparently unrelated medications that can affect heart rate variability, that this has been something that when we started doing this has crossed my mind many times on how to potentially isolate that or create an environment that you can control for those many variables. I think in this situation, you'd have to design something that is a little bit more prospective, and then select patients that will not be using some cardiovascular altering medications, which will significantly reduce your pool of applicants. I think this may be the reason why you have so many studies talking about endurance athletes and people who you would expect are very healthy and that care about their routine of sleep and feeding and just general health more, because those would be the cleanest subjects for any type of studies. But of course, with that, then you limit the clinical applications. I would be more interested clinically, as I think some clinicians are, and okay, I can see this having a role in athletes, but how can we look at our sick patients that unfortunately will have a messy list of medications and all that? So I think we have to deal with the fact that it's not going to be perfect, but if we want to use this non-invasive tool, we will have to take this into consideration.
Well, it sounds like you might have to, and since you're young, you can do it. Sounds like you might have to do an actual experiment on something like HRV and neurology residents on call to get a clean study.
Oh no, do we want to do that? All right, I think Dr. Ramel has,
I've enjoyed this very much. Thank you. I love the fact that you started out with the anatomy. That's fun. We noticed here in one of our primary care physicians in the HCOC has asked us to get involved because many of the COVID patients are having dysautonomia. And, I know you can look at this just in the clinic, looking at heart rate variability and sympathetic skin response. But anyway, have you come across anything in your reading? Has anything popped up regarding COVID and dysautonomia or heart rate variability?
Wow, that's a very interesting potential relationship. But I have to say that when I was looking at this, and I started looking at this after the pandemic has started, and so I would expect that we would see, but and of course I won't say that I looked for it specifically, so I don't know if I used the keywords, and for some reason that didn't cross my mind, but that's a very, very interesting possibility to look into. I would assume, as you're saying, that we would see some dysfunction, but I have not seen this described.
Well, this particular faculty member who's in primary care is interested in partnering with us and others on campus to look at this. So if you're interested, I'll bring you into the fold with several of us that are going to be helping her.
Oh, that would be
Thank
fun.
you.
You know that I'm always interested in getting involved in those things. So thank you.
Yes, I know that.
Sharing. Yeah.
You did a great job today. It was fascinating and very well delivered. Thank you.
Thank you. Thank you all for your attention and spending some time with me here.